Welcome, friends of the Retina Channel podcast, to episode 85 of this series. This is a special episode, a rather unique episode, because it's a collaboration between the Canadian Ophthalmological Society, COS, and Canadian Retina Society, CRS. And on behalf of the Canadian Retina Society, I hosted and moderated a session of the E85-EyeNovation webinar series, hosting our friend Dr. Usha Chakravarthy, who has been on this podcast before a few years ago. And she kindly talked to us and the wider audience of the E85-EyeNovation webinar series about the importance of the double layer sign in neovascular macular degeneration. And she drew on the results of the EDNA trial, which looked at the risk factors of conversion to macular degeneration, neovascular macular degeneration. And this was a fantastic back and forth and interactive webinar series with panelists on the webcast. And I really learned from this conversation, and I think it received a very warm welcome from wider audience and who were all tuned in live when we were having this recording. So the introduction for Dr. Chakravarthy will be on the actual webinar, so I won't repeat that. And I hope you find this episode helpful. And he's Dr. Chakravarthy.
Hello, everyone. Welcome, our community worldwide and ophthalmologists in Canada, to our retina-focused section of E85 webinar, which is an initiative by Canadian Ophthalmological Society. My name is Kevon Kushan. I'm a co-chair of Scientific Planning Committee of the Canadian Retina Society. And as on behalf of CRS, we are delighted to collaborate with COS to host a series of retina-focused webinars for everyone. Today, I have the distinct pleasure of hosting Dr. Usha Chakravarthy from Belfast, UK, who will be presenting her talk on the value and importance of the double layer sign in macular degeneration. She'll be drawing on the results of the EDNA trial, which is early detection of neovascular AMD trial, that investigated and compared the value of different diagnostic modalities to monitor the progression of to exudative neovascular macular degeneration. So these are EDNA trial looked at people who had neovascular AMD in one eye and looked at the diagnostic modalities to predict the conversion of the other eye. Dr. Chakravarthy is a renowned retina-trained ophthalmologist from the UK. She really needs no introduction. She has been a pioneer in our field for many, many years. If you look up any major study in retina, her name is on the paper. So really, we are so blessed to have her on this webinar. She is the professor of ophthalmology at Queen's University at Belfast, director of ophthalmology service at the Belfast Health and Social Trust until 2015. And as I said, she has innumerable contribution to retina research, especially in the field of AMD. She has been as the study chair for many national, international clinical trials, cohort studies, epidemiological investigations. She has chaired advisory groups and was a member of key task force in retinal diseases, including International AMD Alliance, Lasker Foundation, and Retina International. So she has had obviously many awards and recognitions, but of note, the one that comes to my attention is that she was appointed as a commander of the Order of the British Empire for the services to ophthalmology in the UK. So today's presentation with Dr. Chakravarthy hopefully will have three key learning objectives. One is understanding of double layer sign and its clinical relevance. Two is examining the double layer sign influences and on the progression from intermediate to late macular degeneration. And the third is exploring the relationship between double layer sign and what we call the SIRE sign, which Dr. Chakravarthy will tell us is sort of a subtype of double layer sign, if I'm not mistaken. And so this session will be hopefully engaging and informative. And all of us will learn something from it. I have to thank also our panelists of this session who kindly agreed to come and be with us and to help the learning for the community. We have ophthalmologists and retina specialists from across Canada. We have Dr. Jeff Williams from Calgary. We have Dr. Nufra Bakshi and Dr. Alan Berger from Toronto, and Dr. Cynthia Kwan from Montreal. I want to thank them all for joining us, and hopefully we'll have all some major contribution to this show. And so without further ado, here's the floor to Dr. Chakravarthy.
Thank you very much. I'm just about to share my screen. I hope you can all hear me.
Yes, we can hear you.
Fantastic. I'm Usha Chakravarthy from Queen's University of Belfast, and thank you very much, Kayvan, for that introduction. I'm going to discuss the predictive value of the double layer sign in high-risk second eyes in AMD. Here are some disclosures of mine, none of which are relevant to this presentation, and this work was published in Ophthalmology Retina just last year. So what is the double layer sign? And this particular sign has been accepted as a biomarker for non-exudative neovascularization. It's really only got into our consciousness when spectral domain OCT came into our routine care. So either spectral domain OCT or swept source OCT a feature is the double layer sign, and it affects the outer retinal layers. Essentially, it's a separation of the retinal pigment epithelium from Bruch's membrane. So let's have a look at the outer retinal anatomy to orientate ourselves on exactly what these different layers are. Normally, this hyperreflective RP layer is opposed closely to Bruch's membrane. In our international nomenclature consensus group, we identified multiple layers of the outer retina. If you look at number 9, I'll see if my arrow is visible to you guys, but if you look at number 9, the external limiting membrane is faint linear line that you see in the outer retina, just external to the outer nuclear layer. And then you have another highly reflective layer, which is the ellipsoid zone containing all the mitochondria of the photoreceptor outer segments. And then there's the interdigitation zone, which is still a matter of some kind of contentious debate, and which probably reflects where the photoreceptors interact with the retinal pigment epithelium. And then, of course, the highly reflective RP itself, which we call the RP Bruch's membrane complex, because you cannot really separate these layers. Now, in eyes that have intermediate AMD, irregular elevation of the RP is thought to signify the presence of new vessels, but not in the presence of exudation, actually in the absence of exudation. Giuseppe Kirkus et al. Were the first people to publish on this, and they looked at ICG angiography and found that there was a network of vessels that did not leak on fluorescein angiography, shown in the ICG angiogram just to the right of the fundus color photograph. And in such eyes, when you take an S-spectral domain OCT, you can see that there's a space opening up between the RPE and Bruch's membrane. Subsequently, Phil Rosenfeld's group, using swept source OCTA, showed that the double layer sign contains perfusing networks of vessels. Here you can see the double layer sign shown by the yellow text and arrow, and on the OCT, on the flow panel shown in the middle of the three images, there is angiography. OCT angiography shows perfusing blood vessels. And this was published in Ophthalmology Retina as long ago as 2019, nearly 6 years ago. After Phil published his work, Robin Guymer's group in Australia showed that certain characteristics were more likely to be associated with a network of vessels on OCTA. what they did was they took spectral domain OCT scans of patients who were attending their clinics when they also had OCTA in many of these patients. So when they looked at the RPE Brooks complex, which is the magenta line shown in the top panel, there is heterogeneous reflectivity if you look at the middle panel between the RPE layer and Brooks membrane. And this heterogeneous reflectivity is a critical element of the presence of a double layer sign. But what Robin's group did was they also measured the width of the separation and its height, and they found that a length greater than 1,000 microns and a height less than 100 microns of the maximum separation was strongly associated with the presence of blood vessels on OCTA. So it was like a check of what type of double layer sign actually contains these new vessels. And this was published in Ophthalmology in 2020. But there are a number of unanswered questions. First of all, if the DLS is present or absent, how does it affect progression to exudation in high-risk eyes? And is the rapidity of progression to exudation affected by other ocular and systemic risk factors? And how does the double layer sign compare to the SIRE sign? Do these characteristics of length and height really matter? Now I'm going to stop there and tell you about the EDNA dataset, and then I'll tell you why we use the EDNA dataset to answer some of these questions. Now, the EDNA study was a longitudinal trial. It consisted of we enrolled a high number of people who had wet AMD in their first affected eye and therefore were at very high risk of NAMD in the fellow eye. One thing to bear in mind is that these participants were enrolled when they first developed wet AMD in one eye. So they couldn't have had a long-standing lesion in one eye, and then the fellow eye and the participant could not have been enrolled had that been the case. And approximately 25% of these high-risk eyes progressed to exudative AMD over the 3-year period of the study. And this conversion was detected at the point of development as the participants were being reviewed mostly monthly for treatment for the first eye. And this EDNA repository of data and images is available at Queen's University of Belfast. So the EDNA study also had a pre-specified protocol, and the grading was performed by Network UK. So on fluorescein angiography, graders had to first confirm the presence of wet AMD and enrollment at the first eye, and then subsequently, because these images were being transferred over at specific time points, conversion to NAMD when this occurred. And also on the spectral domain OCT, all the B scans and the volume scan were scrutinized, graded for drusen size, type, distribution, pigment migration. Any foci of atrophy were recorded. The B scans were also graded for the intactness of the RP, EZ, and ELM, and choroidal thickness, but the presence of a double layer sign was not included in the original EDNA grading. Now, the EDNA study main paper was published in Ophthalmology, and this was a couple of years ago. But I want to just point out what happened in the EDNA study itself. Because this was a study that was conducted during routine care over the 3-year period, patients were returning mostly every month for their injections, and at these time points, and at every visit, several tests were performed. The first was a self-report of change in visual acuity. Excuse me a minute, I'll turn off my phone. Okay. An Amsler grid was given to them so that they could check for distortion. There was a clinic-measured visual acuity, fundus imaging, color, and spectral domain OCT was carried out. Now, but there were also very specific study visits at baseline, 18, and 36 months. And during any period during follow-up, if the patient phoned up and said they had distortion, or at any clinic visit, the study eye, which was the unaffected eye at baseline, was thought to have developed wet AMD, the patient was immediately subjected to a fluorescein angiogram, which was the diagnostic test for calculating demonstrating accuracy and specificity of these follow-up tests. And so we had very robust data on exactly when conversion occurred. So this is again the EDNA flow diagram. 578 consented take part, a few were consented in error, and very few withdrew consent for their data to be used. So we were left with a cohort of 552. And in 80 of these patients, 25 conversions were diagnosed without FFA. So that means there was no fluorescein angiogram after enrollment, but all the rest had fluorescein angiography at a baseline, 18 and 36 months, or if there was a trigger indicating the conversion, that is distortion, Amsler change, etc. And you can see in total, there was 145 patients who developed neovascular AMD and 336 who did not. And in 8, the fundus fluorescein angiogram was indeterminate. And here you observe the time to conversion and of the 145, 120 with a fluorescein angiographic confirmed diagnosis. So 25% developed wet AMD, which fits perfectly with some of the prior data from many years ago. And various tests were performed. And as you can see, as the patients developed wet AMD, they were censored at that point, and they moved into a different study called the FASTBAT study. But therefore, you will see that the range of the number of tests that were performed, I've highlighted those CT tests, was 1 to 35, because some of the patients developed neovascular AMD very rapidly, and therefore they don't appear in this calculation. Now, the double layer sign obviously could represent the first evidence of blood vessels growing between the RP and its basement membrane, and therefore is considered to represent a very key biomarker for more rapid conversion to neovascular AMD. But there is insufficient evidence to date on its role as a predictive biomarker. So what are the reasons for us to use the EDNA dataset? Well, it was a standardized data collection, there was reading center grading, and we have a robust curated dataset repository. There was there were 145 eyes that developed neovascular AMD, giving us sufficient power to detect associations. So with the EDNA dataset, we were able to test if the presence of any DLS at EDNA entry influenced rapidity of progression, and did the severity of the DLS influence rapidity of progression, and did the features of the SIRE sign improve predictability of progression. So as over here, you can see the various different OCT platforms were used, and we had information on the scan dimensions, the area covered by the scan density, and we had a full repository of scans from baseline 18 and 36 months, plus those that happened at the trigger visits and any other interim clinical visits where there was any question of conversion to wet AMD. And the total number of SDOCT scans in the repository are around 3,000. So a second stage grading was performed. Now, graders were initially trained on an independently acquired pre-graded dataset, which Phil Rosenfeld and Nadia Waheed provided on how to recognize heterogeneous reflectivity in between the RPE and Bruch's membrane, which is a critical element for the diagnosis of the double layer sign. Now, the flow of grading was all the B scans of a volume scan were scrutinized, and any irregular elevation of the RP due to drusen were identified. If irregular elevation was present, it's scrutinized for features of the double layer sign and recorded. The most affected B scan with the DLS was used to measure length, that's the horizontal dimension, the height, the separation of RP from Bruch's, and the number of affected scans, because remember that the double layer sign can affect many B scans, so that was the extent. And then a SIRE was not graded separately, but rather eyes with features of SIRE could be extracted because the measurements had been made. I'm just going to show you some examples of the grading flow. So here are examples of irregular elevation of the RPs absent, but there's drusen present. So there's no separation at all, but there's either basal laminar deposit, drusen, and subretinal drusenoid deposit. Then a space can open up between the RP and Brooks, and this is when we called it the irregular elevation of the RP. Now, if the reflectivity of the separation is homogeneous, this is not a double layer sign. If the reflectivity is heterogeneous, it was classified as the double layer sign. The scans, as I said, was not graded for SIRE. SIRE is a subset of the DLS purely by virtue of its length and height, and is therefore a derived variable in our data set. There were other features that are known to affect risk of progression, such as how severe was the nodular drusen, whether there was hypertransmission defects, that is, early features of atrophy, the development of hyperreflective foci, which are migrated into the outer and mid-retina, and the presence of subretinal drusenoid deposits. These were all graded as well. Now, here, this is the paper that we published in Ophthalmology Retina. So I'm just going to show you the flow of the participants. As I said, 459 had sufficient data for us to include in this analysis. And 58% had irregular elevation of the RPE, 41% did not. That is, the RP was not separated from Brooks, even though there were multiple types of drusen. And of these 268, that's the 58% with IE, the DLS was present in 38% and DLS was absent in 62%. And then when we looked at the DLS sign, SIRE was present. SIRE was absent in 50% and present in 50%, divided up nicely. And as I said, this was a derived variable. So here are the baseline characteristics, but what I want to show you here is that in our analysis, we had overlapping categories and exclusive categories of these signs. So you will see that those eyes with DLS will be in the IE category, and SIRE eyes will be in the DLS category and the IE category. We also looked at exclusive categories, that is IE only, DLS only, and SIRE only. Here are the Kaplan-Meier survival plots comparing time to development of exudation by IE, DLS, and SIRE. Now, the first panel shows the presence of the progression when any irregular elevation was absent and when it was present. And as you can see, the presence of any irregular elevation results in an increased risk of progression. But even when there was no irregular elevation, there was still a risk of progression. Then when we look at the next Kaplan-Meier graph, this is the double layer sign absent versus double layer sign present. You see the dramatic increase in progression. And then when you look at SIRE absent, SIRE present, there's really no great difference between these, the panel showing the double layer sign absent versus present and SIRE absent versus SIRE present. Now, looking at the time to development by the exclusive categories, you see how the presence of the DLS only and the SIRE only overlap almost exactly, indicating no additional risk by obtaining information on the dimensions.
Dr. Chakravarthy, can I interrupt for a second?
Sure.
So just want to summarize our understanding so far. So we have irregular elevation of the RP or IE, which is the broader category of abnormalities you discovered. And that includes the DLS, which is you have a certain heterogeneous elevation.
Yes.
Correct? So far, I'm correct. And then
right.
a further subset of DLS is SIRE, which includes the height of 100 microns and the length of at least 1,000 microns. So that's a smaller subcategory of
the
DLS becomes SIRE.
Yeah. Correct.
So, and all those three levels of categorization, the increased rate of conversion to neovascular AMD, but you just showed us that SIRE necessarily doesn't increase more than the bigger category of DLS, correct?
Correct. And when you look at DLS and when you look at a subcategory, if you take just the DLS group and split them into DLS and SIRE, they overlap perfectly.
Okay, thank you very much.
Okay. Any other questions before I move on to the modeling that we did?
Any of the panelists, any comments so far before Dr. Chakravarthy moves on?
Dr. Chakravarthy, were you surprised that so many of the patients already had DLS at baseline or had IE at baseline? Or did you
Not at all. These are all patients who've already got neovascular AMD in their first eye. So by definition, when we diagnose the patient as having neovascular age-related macular degeneration, you invariably find drusen in the fellow eye.
And was there a reason that OCT angio wasn't included as one of the diagnostic modalities?
It was too early. This study was commenced in it was conceived in 2014, 2015. By the time we got approval for it to be done and the funding put in place, it was 2016, and most sites it was a pragmatic study. It was not intended to look at risk factors for progression. It was intended as a diagnostic accuracy study. So it was a pragmatic design. And of course, at that stage, only about a third of our sites had OCTA. We do have a subset with OCTA, but not everybody. So we couldn't include it in any of these analyses.
Thank you.
So we also looked now at modeling some of the baseline characteristics by whether they had IE, DLS, and SIRE. And so some interesting findings. Age was not different, but of course they already all had wet AMD, so they were all in that age group. That was quite a tightly clustered age group. But when you look at the gender, female gender was more likely to have these greater abnormalities of the RP Brooks complex, if you want to put it that way, compared to male gender. Smoking was also, you could see a slight differences, and I'll talk about it in a moment. And then, of course, all these other features are all collinear: the presence of nodular drusen, subretinal drusenoid deposits, intraretinal hyperreflective foci, hypertransmission defect. These were all more commonly seen in eyes that exhibited these RP level abnormalities. And they're all collinear, they stack together. So now we can look at the hazard ratios of progression, model it, adjusting for all these confounders. And when you look at it, you can see in the top one, this is the hazard ratio for the presence of IE versus no IE. You see an increase in risk. Smoking also, the point estimates, the squares, the fill squares indicate the point estimates, and you can see they all lie to the right of the central line, indicating an gradual increase in risk by whether never, ex or current smokers. And you see this pattern throughout the forest plots for the DLS and for SIRE as well. And but the maximum hazard ratio is for the presence of DLS and SIRE. So if I can look at it over here, it's about coming up to about 3, the odds ratio just over 3 in most of these comparisons for IE, DLS, and SIRE. But then when we now move to the hazard ratios by the non-overlapping category, so you can see the top section of the forest plot, no IEs, the reference category, IE only, DLS only, and SIRE only. You see a nice gradient for the first 2 steps, but DLS and SIRE overlap. And interestingly, family history popped up. It was just failed to reach significance, as did female gender. So there seems to be maybe an additional contribution, and we're in the process of investigating in a predictive modeling study the role of genetics risk in this cohort. And smoking, again, you can see that the point estimates are gradually tending in the increasing risk. Okay, so now let's look at the dimensions. So you have that we measure the height, the extent, and the length, and when we looked at progression to exudation by these categories, we found absolutely no differences in the mean and the median, and we looked at the interquartile range and we looked at quartiles, etc. And there was really no indication that the dimensions played a role and when we looked at the overlapping categories. And here you can see the scatter plots for each of these measures, that is the extent, the length, and the height for the irregular elevation of the RP, DLS, or SIRE. There was no differences. We also did a sensitivity analysis looking at the non-overlapping categories by progression to exudation. Again, we found no indication that measurements are of any value. And here again are the scatter plots, the median and the interquartile ranges for extent, length, and height of separation by progression to exudation, no or yes, for each of these parameters. And then we finally looked at the frequencies of the type of exudative MNB by these categories of eye, DLS, and SIRE. We remember, of course, that by the time you start to break it down by type, and you're looking at smaller numbers and smaller numbers, but there seemed to be a hint that the type 3 RAP lesions, there was a greater predominance of these RP level changes. And the question is whether this could have just been the risk associated with subretinal drusenoid deposits. So here are my take-home messages. Conversion to exudation was highest when the RP was separated from its Brooks membrane, and risk was highest when features of DLS and SIRE were observed. Eyes without irregular elevation, or that is just some drusenoid changes in the outer layers, also progressed to exudation, but the rate was low. So the separation of Brooks and RP from Brooks is an important feature of increased risk for progression. The extent, length, and height of the separation of the RP from Brooks membrane did not alter the risk of progression, and the predictive ability of the SIRE was no different to the DLS. Family history and smoking increased the risk of progression independently, but these effects were small. And the DLS is a very pragmatic biomarker, easily recognized and applied in the clinical setting and useful for counseling high-risk patients. I want to acknowledge Phil Rosenfeld and Nadia Waheed, who played an important role in the training of our graders in detecting the DLS and identifying it, and also the graders who did all this work, David Wright, who is our statistician, and Tunda Petto, my colleague, who is the director of the Reading Center and supported this work very extensively. Thank you for your attention.
Well, thank you, Dr. Chakravarthy. That was fantastic. This is something that a lot of people don't know about. It's amazing how DLS is not advertised as much as it should. I remember I heard the talk from Dr. Rosenfeld you mentioned. I think the context was about central serous retinopathy. And he mentioned that there was a talk about which one has neovascularization, which one has. Maybe that's something we should talk about. And then since I've been paying attention to it, I can see it, but normally I wouldn't look for it. So thank you for bringing this to our attention and doing more work on it.
It's very easily detected because all you have to do is, if you have spectral domain OCT, just flick through the volume scans and look at the look for separation of the RP from Brooks, and it's easily visible. When it's present, it's easily recognized. If you don't see the separation, you know that it's not there. Okay, so
yeah. So maybe I should ask the first question, and just following what Nupra said. So say with your current experience and your current cohort of tools, including OCT angio, what percentage of eyes with DLS do you think have actually a non-exudative AMD, like a non-exudative neovascular AMD? So it's essentially a dormant neovascular membrane.
So you're really asking what proportion of eyes, when somebody first presents into my clinic, will have detectable new vessels on an OCTA.
Oh no, what proportion of eyes you see with DLS? So someone
Okay.
comes to my
Okay.
office, both
Yeah.
eyes are dry AMD, no exudation, but I see DLS in both eyes. And so what percentage of these patients probably have a non-exudative neovascular AMD? Is just, and if I do OCTA, very good OCTA with no errors, it would detect a neovascular melanoma.
I can't remember the exact figures that Phil has quoted, but if they have a DLS, then my guess is that it's going to be 1 in 5 when OCTA will pick up new vessels. There are two types of DLS, and we did not go into this because we haven't done that analysis. So you have thin DLS and thick DLS. If you have thick DLS, you're much, much more likely to see an OCTA signal in those eyes. The big question is, if you see the DLS and you see new vessels there, are they going to exude? And the answer is yes, they're more likely to exude more quickly than eyes that don't have it. But to predict exactly when that exudation is going to happen in an individual is going to be extremely challenging.
And I guess how frequent to follow them.
Yeah.
Right. That was a question I was going to ask Usha. I think this is, first of all, a fantastic review, fantastic photographs. I haven't heard a talk that more clearly educated me as to what DLS is and what to look for, and so this was fantastic. And I think it's important. Obviously, in our patients who have fellow eyes with wet AMD, we're probably seeing them quite frequently anyway. But my question was going to be, along the lines of what Dr. Kushan said, or in our what's your current protocol? So if you have a patient who either has lost vision in one eye from a disciform scar or has geographic atrophy in one eye and has DLS in the fellow eye but is not symptomatic, OCTA would probably be a test that we would do. But how has it changed your timing of assessing the patients?
Okay, so if the patient is having treatment in the first eye, that makes it very easy. They're coming up regularly. If the patient has a dead scar in one eye and the fellow eye has a DLS, then we kind of counsel the patient very extensively. You don't really want these patients to clog up your clinics. I mean, none of us do, but you don't really want them to go off and not be seen, and they get a lesion from which you might find it difficult to restore function.
Right.
In those patients, I think that we obviously have insufficient clues as to what their reassessment intervals should be. But in the first instance, most of the conversions, this is something I should have probably indicated, but it wasn't part of our DLS study. It was part of the EDNA study. Most of a high proportion of the conversions actually happened within the first 18 months. And the longer they went without exudation, the less likely they were to exude. Okay, there was a kind of a probability curve that showed that if you there are some systemic factors that clearly are operating, triggering that neovascularization. That's according to me anyway. And then, therefore, in the immediate aftermath of the first eye developing neovascular AMD, the second eye does too. And so if you have somebody with an old dead scar in one eye and the fellow eye has not converted, then I think that I would hedge my bets and go, I will see that patient once every 6 months or 1 year. But I would warn them to really focus on their function, their vision. The other eye is gone anyway, so they're dependent on it. And I would want them to report any changes fairly quickly. There is a confounder here. So they might be getting cataracts. It's that age group, unless they're pseudophakic. So sometimes they don't recognize changes in function. And we observed this in the EDNA dataset. If you read the first paper that we published in ophthalmology, we actually found that visual acuity was had very poor sensitivity. And the AMSLA also had terrible sensitivity. It was even worse than just asking the patient to just cover one eye and report whether they had any distortion. So it's a difficult situation. And this was the reason why we performed this study in the first place, to see whether we could put OCTs into our optoms clinic so that the patient could just go over and get a OCT scan maybe every 3 to 4 months.
Usha, can I just ask you about those systemic factors again? Because I had a question that came from online as well as my own that relates to the forest plots. And in the forest plots, I mean, the hazard ratios were obviously positive or worse for people who had double layer sign, et cetera. But there were some negative ones, like slightly predictive if you were, or protective if you were on a supplement, for instance. But I noticed hypertension also came out as being one that was maybe a little bit more protective. Could you expand on that?
Okay, so, well, one of two things. First of all, it could just be a confounder, and we don't know. But the second thing is any patient with hypertension is often on multiple types of medication. Our NHS health service tends to, so that was a history of hypertension. By the way, this was not recorded blood pressure. So they would have been on statins, they would have been on various medications to control their blood pressure. They're probably seen more frequently by their GP for all these systemic conditions. So and also they might have implemented lifestyle changes, stopped smoking. There are various things that happen in these contexts. So while, and again, if we'd had a 2,500 sample, we might have been able to dissect these out better. But with the 450, it would have been almost impossible. But you're very eagle-eyed to spot that there was a slight benefit in terms of the odds ratios or the hazard ratio shifting to the left with supplementation. There was a signal there, but it wasn't very convincing.
Okay, thank you.
Usha, can I just ask your opinion again, going back on the DLS sign and the SIRE sign, which I think you really illustrated beautifully. A lot of our listeners are, they're retina specialists, but there are also many who are injectors. And I think being able to see these signs just by OCT is really helpful because not everyone has access to OCTA, as you said. And my question is, from your data, what would be the possible added value of looking for SIRE? For example, I think detecting the DLS sign here would be easier. You just need to look for that separation, that heterogeneity. For SIRE, you have to kind of measure it, measure the height, measure the length. So do you see added value, and what kind of context, if not here?
Well, in a pragmatic sense, in a clinic, there's absolutely no way that we're going to be measuring for SIRE. On the other hand, I don't know if we had a much larger sample and we continued to explore the value of the SIRE sign in terms of additional data, say, for example, combining SIRE with some other features like the presence of pseudodrusen, subretinal drusenoid deposits, or if you were to remove, say, let's just say, don't worry about the height, just look at the length. Does that matter? We haven't done any of those kinds of analyses with our data set. So you could sort of mix and match to see whether you can pull out any risk factors amongst the other ocular features that we graded to see if any of those might help in understanding the value of the SIRE sign in a more research context, or maybe or for a clinical trial purposes. But on a pragmatic level, we would never bother making these measurements. You just look at the scans and you go, well, there's a DLS or there isn't a DLS. And if there's a DLS, you then say to the patient, look, there is an increased risk. Be very mindful that your fellow eye could develop this condition. If you're smoking, stop it immediately, and and consider the Ares vitamins. Though I'm not an enormous fan of Ares vitamins, but it makes everybody feel a bit better. Give them something.
Great take-home message.
I'm gonna ask one more question and also encourage all the participants online, folks, to put their questions in the chat box. Hopefully, we can address that. Dr. Bakshi, did you want to have another question before I go ahead?
Sure. Dr. Chakravarthy, thank you so much. That was a fabulous and, as Ellen said, very clear talk, and I think it had a really important number of practical pearls, and especially what you were saying about bringing patients in sooner for follow-up, and as Cynthia said as well, many patients who have bilateral dry AMD are often seen by general ophthalmologists or sometimes even optometrists. They don't necessarily get to the retina specialist until there's more evidence of exudative changes, and so I think that importance of screening that you pointed out and bring them in sooner is really key. I was wondering, just to clarify, when you were talking about the patients who have the DLS versus just the IE, really it's the heterogeneity, right? That's a critical part of the difference there.
Correct.
Is that what you were saying? And then did you find any association with pachychoroid spectrum, or how did the DLS tie into that population of patients?
Interesting question. We did not see many eyes with pachychoroid spectrum, but what we did observe was that choroidal thinning, when we did do a bit of predictive modeling, but we kind of put that on hold because we wanted to include the genetics as well, because they hadn't got the genetic, we hadn't got the GWAS back from the blood samples that we took at that stage. But what we did observe was that a thin choroid was associated with a higher risk of progression. It's sort of it seems counterintuitive, doesn't it?
What were your thoughts on
all these blood vessels? But the fact is, I think the thin choroid probably means that the RP is dying, it's migrating, and you get more hyperreflective foci that you see, which Christine Curcio says are migrating RP cells because Bruch's membrane is hostile, and so they are the ones that progress.
Interesting, thank you.
Very interesting. Yeah. Go ahead, Alan.
Yeah. I had a question. I mean, more and more retina specialists do have OCT angiography now, and yes. I guess these signs that you've described to us obviously are critical. Our system is very much like your system. We're overloaded with patients. I'm sure from an anti-VEGF perspective, we have a tendency to overtreat patients, but we're happy to do that because we think we're getting better outcomes. You can almost say the same thing about follow-ups, right? I mean, but something like this will help us sort of triage or stratify who gets seen more frequently. And so if somebody has a positive OCT angiogram, if we include OCT angiogram in our battery of tests on anybody who has DLS, would you I mean, intuitively, it sounds to me like that would be somebody I would be even a little bit more worried about, or bring back even a little bit sooner than someone who had DLS without anything on OCT angiography. Do you agree?
Right. Or? And I'm not sure that I agree, and I'll tell you why. Because when you have this network of vessels underneath the RPE, external to the RPE, it's bringing nourishment to the RPE. And a quiescent, dormant network of vessels without exudation might actually be maintaining the health of the RPE. Now, if you look at the pro-con study that was done, it wasn't a great design, but it showed us that the presence of these signals on OCTA the presence of dormant neovascular complexes did not increase the risk of progression to exudation. And they actually treated with anti-VEGFs, if you remember, and that also did not make any difference. So.
To piggyback off Ellen's question, do you think that all patients who have DLS should get OCT angio, or how do you decide in your clinical practice?
Well, we don't do OCTA just because of the presence of DLS. We do the OCTA because we moved away from fluorescein angiography to detect the presence of a neovascular complex, that so that you want to make the diagnosis that there is neovascularization. You don't want to misdiagnose CSR or a choroidal nevus, or a vitelliform or something like that, that you think on OCT looks like exudative AMD, but it isn't. So for that purpose, we would use OCTA. We would also use OCTA if we want to do a very deep, intense phenotyping of the patient. But these are sort of research level patients. On a pragmatic level, we just don't do OCTA all the time, but we do an OCTA as a confirmatory diagnostic test to show that an exudative lesion that you see in the macula has got new vessels in it.
So for the trial, the patients that didn't get fluorescein, for the 25 patients, did you get OCTA to confirm prior to treatment, or is that part of the trial design?
No, it was not part of the trial design, but invariably the clinicians did do an OCTA on those patients. So we have the data sitting there, though as part of our protocol that was not meant to be analyzed. So that is sitting separately, but they are being looked at.
Can I just ask one other quick question or make a quick comment, which I think I've gleaned from what you said, and that is that the presence of DLS is not an indication of active neovascular leakage, is not an indication for anti-VEGF, because certainly in various areas we see certain doctors treating anything that looks vaguely like fluid, just like outer retinal tubules. You shouldn't be treating. DLS alone is an indicator, is something we want to look for, but it doesn't indicate active blood vessel leakage that requires anti-VEGF. I got that right?
You got it absolutely
okay.
right.
Thanks.
Jeff, did you have a question as well?
Yeah, I'm just asking on behalf of James Whalen, who's in Newfoundland, who's probably the closest to you, Usha, in Canada. He asked here, the vast majority of your scans were Heidelbergs. From a reading center perspective, is there a difference in detection of DLS between the different manufacturers?
No, not if you look carefully. The aspect ratio in the Heidelberg is 7:1. So in fact, it increases the way when you look at the scan, it's expanded, okay, in the vertical dimension. So it's somehow easier to look at in that context. But we were able to grade for the DLS just as well with all the other imaging modalities. The reason why we have a much higher number of Heidelberg scans, because a high proportion of our sites had the Heidelberg, and obviously good marketing on their part, because most of our sites did have the Heidelberg. But of course, we also had Zeiss, we had Topcon, and the occasional other stray ones that I can't even remember the names of.
Thank you.
Thank you. Usha, maybe I just want one last question. I want to expand the pachychoroid discussion a bit further to a younger crowd. With CSR, chronic CSR, sometimes you have this chronic subretinal fluid with some DLS. Do you think there's any value in paying attention to that? Maybe there's secondary CNV on it. What's your practice when it comes to those younger patients with CSR?
Okay. So in the CSR, and if they have very chronic fluid, and if you see the double layer sign, then there is a very strong possibility that the CSR is becoming neovascularized, and that at that point, adding an anti-VEGF does seem to be beneficial. That's in my hands. That's what I found. And you're right. I mean, in this pachychoroid spectrum, when we see patients with CSR, our algorithm is do nothing for the first 3 to 6 months. Doesn't go away, then have fluence, or half dose, or both half fluence, half dose PDT. That makes a big difference in our hands. And then subsequently, if it still doesn't, we still don't see any resolution, then we would investigate that patient much more carefully, because there are other reasons for why the patient may have the cystic fluid collecting in and around the neurosensory retina.
Thank you very much. Any other questions, our panel? So if there isn't, I want to close down. Really, thank you very much, Dr. Chakravarthy, for coming from over the other side of Atlantic Ocean. It's almost 11 o'clock at nighttime. So in Belfast, I really appreciated you giving us your time and being flexible in how we schedule this. It really means a lot to us. Hopefully we'll get you back here in a COS meeting in person or CRS meeting in person. That'll be fantastic. And then also want to thank our panelists for giving us their time and adding to the discussion. That was really wonderful. Hopefully we all learned from this discussion. And also some housekeeping items. As I mentioned, CRS is collaborating with COS in doing a few of these webinars. So we have 3 more for you folks coming up. Next month in March, we'll have Dr. Angie Fong from University of Hong Kong, and she'll be talking about the topic of polypoidal vasculopathy and CSR. And then in April, Dr. Robin Geimer from Melbourne, Australia, will be joining us. Usha mentioned her work in the SIRE sign, so maybe we should ask her to talk about SIRE sign.
She'll not be happy.
So she'll be talking to us in April from Australia. And then in May, Dr. Ioannis Dimopoulos from University of Ottawa will be talking about inherited retinal diseases, what's new and what's in pipeline for IRDs. And that's it.
For asking me to come along and speak to you guys. But I'm glad I'm not in Canada right now.
Very cold, very snowy here. Well, thank you again, Dr. Chakravarthy. And with that said, everyone have a good night, and thank you for joining us.
Thank you.
Thank
Bye-bye.
you.
Thank you very much.
Bye.
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 Well, folks, this wraps up episode 85 of the Retina Channel podcast, which was also a recording of the EyeNovation webinar with the Canadian Ophthalmological Society and hosted Dr. Usha Chakravarthy. I want to thank her for coming on the show and doing all the preparation work that needed to be done, considering the time zone differences between Toronto and the UK, and also our panelists who joined us from different parts of Canada and their different time zones, and to have this wonderful interaction with Dr. Chakravarthy. Well, on behalf of the Canadian Retina Society, I want to encourage all of you to register for the upcoming CRS annual meeting in Vancouver, British Columbia. It will happen from April 25th to April 27th this year. And we have a wonderful array of speakers and also wonderful submissions from Canadian and international attendees. This is promising to be 3 days full of learning with fantastic speakers. And the website to register for the meeting is crsSCR.ca. I'm going to put a link in the show notes. So I encourage everyone to register for this meeting, and I'll see you there. Well, this is it for today, and I'll see you in our next episode in April.